Okay, my dear friends, hello. I'm ready to see you actually from the screen, but I feel your presence, and actually I think that this live broadcast, live Q&A session will be very intensive. I'm not thinking about that. I'm pretty sure because we made the first, like a part one of the live session. We made it on our Instagram recently, a few weeks ago, and we received, like, I don't even know how many questions, more than 1,000 maybe, and we were not able to answer all of them, but we decided to go here on the YouTube to make this extended live Q&A session. I prepared, I will show you some slides, I will show you some videos, so that will be very informative for you, and I'm pretty sure that you will get a lot of tips and tricks that will help you to become even better in your profession. Okay, before I will start answering questions, I would like to ask you if you can hear me. Just let me know if the sound is fine. Just put like a plus or whatever, just to see if the sound is fine. And just for warm up, I see that we have some people watching us live. I would like to ask you where you're from. Where are you watching us from? Which country, which city? That will be also very interesting to see the audience and to interact with you. Being in Czech Republic, in Prague, we are here, but because of the internet we are able to communicate with no limits, with no borders, without any restrictions. Actually, here we can stay pretty long time. I mean, on YouTube, because Instagram was limited to 1 hour. If you missed the part one of our Q&A, by the way, you can go to our Instagram page, and you can see the live stream recorded. So there were a lot of questions also answered. And then I see that we can actually start. We are from London, from Mumbai, from Turkey. Yeah, good. Everything is super good. Kyrgyzstan, nice audience. Please join more. I would like to ask you, before we will continue with this intensive live Q&A, maybe you can share the link to this live stream in your accounts, for example, in your stories, so much more people can join us, and I think it will be more beneficial for everybody, for you and for me as well, because we are able to answer your questions also. Actually, the plan for today, this is what I would like to introduce. The plan for today is to answer questions that I already received. So I have a lot of them. You can we show a slide? Just the slide from the presentation. You can see just like a simple screenshot. There are so many different questions, and I will go slowly, one by one, but then we will also answer. Yeah, thank you for the slide. Yeah, we can go back to myself. So then I will answer your questions, and I think if we will have more people watching us live, we will be able to answer more questions, and everybody will benefit. So please share this live stream in your stories and your accounts, and I think it will be very good from your side and also from my side to answer everything. Okay, so I think that we can start actually with a question. So the question number one that I'm going to answer is the adhesive luting of zirconia worth the struggle. So that there is a question if we need really to bond to zirconia. So that's the question, and the answer is, if you have good retention, for example, the crown preparation was according to the basic principles of crown preparation, you have enough rule, you have retentive part of the crown preparation. So then in this case, you can use any cement you want. You can use glacion, or you can even use zinc phosphate cement if you want, because there is a retention. But if you have, for example, short tooth abutment, or you are doing some kind of non-retentive types of restorations, I'm pretty sure that it's good to use the bonding to zirconia, and this is the very conventional nowadays, the conventional protocol that is by Marcus Blatz. It's from, you see, 2016, and since that time a lot of things changed, but the core principle of bonding to zirconia is still the same. So you use micro etching, sandblasting, like a 50 microns aluminum oxide for about 20-30 seconds. Then you clean everything. Then you can use zirconia primer, or you can use adhesive system with a very high concentration of the MDP monomer. Okay, and then you can use your resin cement. You can use dual cure resin cement or self-cure resin cement if zirconia is thick or it is opaque. But if you use translucent zirconia, relatively thin, we speak about let's say 2.5 millimeters. So in that case, you are able to cure through. So you can use even light curable cement to bond to zirconia, and then you can get your advantages to have adhesion to zirconia. Like in this case, I used bonding of these crowns because the retention was not that sufficient. I had some retention for sure, but together to the retention, I was able to receive adhesion, and then I think that's why not. Why not? It's not struggle based, by the way. It is like a normal way today to bond to zirconia. Okay, another question is, what's your view on connecting a tooth abutment with implant abutment in full mouth rehab? I'm not sure that it's a good idea to connect let's say, stable tooth, because we have periodontium and we have some kind of mobility, the physiological mobility of the tooth, and stable part, which is implant, that has no periodontium and has no mobility. So I'm not pretty sure that it's a good idea to connect your implant together with a tooth abutment. So please don't do that. Okay, let's go next. So what we have here, we have what's the depth you use for each material in crowns. Basically, the answer is pretty simple. You need to read the instruction at least for the material that you are going to use. They are available on the web pages of any manufacturer. For example, Ivoclar, they have a huge, let's say, library of the articles and informational booklets related to the different types of materials, different types of restorations, even different types of preparations for these restorations, and the thickness for sure. Another thing what you have to know is actually the requirements from your dental lab, because sometimes they need more space, sometimes they don't need that much space, so you have to communicate with your dental lab, especially when we speak about the color change cases. Just an example, if we speak about Emax crown, or let's say let's go to the zirconia. There is a zirconia by Noritake that is called katana, and they have different types of katana zirconia, and they have translucent zirconia that can be used as monolithic full contour restoration, just stained glaze, and that's it. And the minimal thickness that you can go for is just 0.5 millimeters according to the instruction. Okay, so that's the thing. But if we speak about the color change, I'm not sure that your dental technician will have enough space having the 0.5 millimeters. So basically he will have to have more thickness of the restorative material to be able to change the color we want. So we have to know the minimal thickness of the material that we are going to use from the manufacturer perspective, and we have to also speak to our dental lab according to the exact clinical scenario, clinical situation, to avoid some kind of misunderstanding and bad results as well. Okay, good, perfect. Let's go next. We have more people now. So basically, let's go for the next question. The next question is, any tip to remove easily partially bonded PMMA veneers? Yeah, that's pain. I know. So when you do a spot etch and spot bond to bond your temporary veneers, it will be not that easy to remove them later on. So we have to struggle. That's the struggle actually. Not bond to zirconia is a struggle. This is struggle. So we have a few things. Let me just show you a video. So here we can see that sometimes in the difficult cases I use thin bore and I separate these veneers. If we have type 3 or type 2 preparations, you have your model, you have your picture, you have your scan, so you basically can see where the interproximal areas to make a very easy and safe separation with the burr. So this is what we do. And then I break these temporaries with hand scaler, for example. My favorite instrument is hand scaler, or this one that you can see here in the video. It is the instrument that is called crown remover. The company name is Task, T-A-S-K, the Task. They produce this instrument. It's not a game changer, I can tell you, but if you have this instrument, your life will become a bit easier in some cases, but I'm not saying that this is actually the one that if you don't have it, you will fail all your veneers removal. It's not like that. But it's good to have this instrument. So first thing, you try to break your temporary veneers mechanically with your hand scaler. If you can't, then you probably will use the thin bore. The best bore, by the way, for that is the multi-bladed carbide. This is diamond, but diamond, if you will touch accidentally tooth, it will not forgive. But if you will use a metal bore like a carbide, it will be better because it's safer. So you can make some splits, separations, then you break your veneers also with the hand instrument. You have to inform your patient in advance that you are going to break these temporary restorations, so your patient will hear cracks. It's not tooth cracks, so your patient has to be relaxed. No worries, we are not breaking your teeth. It's just the breakage of the temporary restoration. So you use your scaler, you break the material, the temporaries, and then sometimes you may have on the tooth surface the part of the temporary bonded to the tooth surface. So what you will do, you will take this metal carbide bore, you will just cut this out. Then you can use soft flex or any kind of rubber polisher just to remove this excess of the material and so on. What I do in such a cases, I can tell you, because you know when you have to keep your patient with a temporary restoration for the long time, for example, if we are speaking about a full mouth rehabilitation, let's say, okay, and we want to test drive occlusion, and we need to keep our patient with these temporary veneers, which is most of our cases on the lower teeth, I bond them. I don't just do spot etch. Sometimes I bond them to the whole surface, to the vestibular surface, to the buccal surface. I don't want to go to the interproximal, but I just get a pretty wide area of adhesive surface, and I bond these temporary restorations, and that's the compromise. Because understand, if these temporary restorations will fail every, I don't know, 3-5 days, I will be not able to check occlusion properly. So I want to make them stay stable, especially if the patient is from another city or from another country. So this kind of compromise we take on our side. So sometimes I bond them, not completely, but let's say pretty partially, and then we have a lot of fun at the day of the removal. So bore separation, hand scalers, rubbers, polishers, and so on and so on. So there is no easy way, my friends. Unfortunately, there is no easy way. Maybe if you have laser, erbium laser, maybe it will destroy the composites, this composite material easier. I don't know. I didn't use it, but we may ask. Maybe somebody. By the way, if we have somebody who is use the erbium laser in your practice, maybe you can just write in comments your experience in that. Okay, so let's see. Maybe erbium laser will be easy way to remove temporary restorations. Okay, so let's go next. The next question is the Good Prosthodontics book. Okay, the book about prosthetic dentistry, fixed and removable for newly graduated dentists. There are so many books. What I can tell you, you can go to the webpage of Quintessence, the most powerful publisher of the dental literature, the best, and you will find a lot of different volumes, books, and so on. But I would like to suggest you, for example, this one from Mauro Frediani. He has 2 volumes. The one is about the like a treatment planning, let's say, and then the treatment itself. So these 2 books must in the life of prosthodontist, because they will give you a lot of information and systematic, the logistics, the sequence and everything. So this is what you will have and you will not regret. Okay, then do you fear recessions after cord placements, and what do you do to prevent them? That's actually one of the most frequently asked questions in our Instagram. Also, we have a lot of questions about that during our courses, and here in today in our live chat, the question number 1 from Ahmed Yassin: does retraction cord cause a recession, and what maximum time to keep in sulcus? This is the question related to the retraction cord placement. So what I would like to tell you, my friends, take a coffee or tea and get ready, because that's the big topic that I'm going to discuss with you right now. First of all, I will refer you to the conventional understanding about the biologic width. Okay, so that's the important thing, because recession may be caused by many different factors. One of the most common factor, iatrogenic, is violating biologic widths during preparation, during retraction, and so on and so on. Okay, so to prevent recession, when we do our preps, we need to know our limits. So here we have like a city light approach, or city light classification, if you want. So this is like a safe zone, like a danger zone, sorry, the safe zone, then we have a risk zone, and we have a danger zone. So basically green, it's a safe zone, it's a sulcus. Ideally, when you do your preparations, ideally is to keep your retraction cord inside the sulcus, ideally. And the most ideally is to keep your retraction cord in the apical half of the sulcus. For example, if the sulcus is 1 millimeter, which we can measure with a periodontal probe clinically, okay, so if the sulcus is 1 millimeter, let's say, ideally is to use a retraction cord that is 0.5 millimeters that you place to the apical half of the sulcus, and the coronal half of the sulcus is for you. So what you can do your preparation within half of the sulcus, okay? So how do we know the depth of the sulcus? As I mentioned, you can actually take a periodontal probe, and then you do very gentle probing till the light resistance. What is light resistance? The light resistance is epithelium attachment, okay? We do it without anesthesia, so it has to be painless, okay? But when you get into the epithelium attachment, patient may feel some discomfort, so that's your limit. And then you know the depth of the sulcus, and then you go with the retraction cord placement, the size of the retraction cord. The problem with the retraction cords, by the way, which is funny thing, is that they are pointed by some strange numbers, like a 000, 000, 0, 1, 2, 3, and so on and so on. So nobody actually knows what is 000 or 000. There is a study that shows that sorry, that depending on the manufacturer, depending on the company, depending on the type of the retraction cord, but let's say 000 retraction cord varies from, as far as I remember, from 0.4 to 0.7 millimeters, or to 0.6. I need to double check it, okay? Then 00 is from 0.7 to 0.9, for example, okay? So this is what we have in our mind when we do our retraction. But if you will go into epithelium attachment during your preps or during your retraction, if you do forced retraction, which is forbidden, the retraction process has to be very gentle, okay? No pressure, no forces. It has to be painless. Even if, for example, you do your preps on non-vital teeth, so you don't need to anesthetize your patient because teeth are non-vital. And when you do retraction, it also has to be painless. That's the rule. Okay, so we don't want to go into the epithelium attachment, but sometimes we have to, because of for example, patient has the high smile line and the teeth are in a different positions, like a zenith of teeth are different, and we would like to correct the zenith by the preparation, then we have to go there. For example, it's a compromise, but we have to go there. So if we go into the epithelium attachment, there is a risk zone actually already, So what we can have recession, or we can have some inflammation, or everything will be okay. So in such a cases, what I would suggest you, if you will go to the epithelium attachment, not to go for the final restoration, but to really use your temporary, but temporary restoration has to be superiorly fitted. No overhangs, no open margins, no cement. Everything has to be polished. It has to be like a final restoration, very precisely fitted to your preparation limit. And in this case, we will wait for about 3 weeks, 3-4 weeks actually, to see how the epithelium attachment will recover. And then you will make a decision what to do next. Okay, and then there is a danger zone, which is connective tissues. That's danger zone, because you may definitely have recession afterwards, or you may get inflammation, you know, this kind of gingiva, which is very red, blue color or whatever. Yeah, so it's very close to the bone. So in such cases, probably we will have to go for crown lengthening, open or closed one, but it's like that. Okay, so this is what we are speaking about in regards of the retraction process, preparation process, and the potential risks to have your recession. So if you do your preparation inside the sulcus, everything should be fine from the biologic width perspective. But another thing that you have to understand is that the violating of the biologic width is not only one reason that may cause recession. There can be something else. Okay, for example, you can do everything perfect in sulcus. Okay, you're prepping the sulcus, your retraction is very gentle, you didn't force your retraction cord. By the way, retraction cord in this case better to have non-impregnated. It has to be dry, and you can keep this dry retraction cord inside the sulcus as long as you want. But if you have impregnated retraction cord, which may cause a potential risk of the recession, by the way, if you will keep the impregnated retraction cord longer than 10 minutes, theoretically it can cause recession. So when you do your preparation, better not to use impregnated retraction cord. It's better to use non-impregnated retraction cord and place it exactly inside the sulcus. That's your safe rules, okay? That's it. But even having these kind of rules, if you follow all these rules, you may still have the recession, which may be caused by other factors. The factor number one, the bad fitted restorations. Like, for example, in this case, we have composite veneers and we have some overhangs, open margins, which acts as the chronic trauma. By the way, the cause of recession is chronic trauma. This is what we also have to understand. So this chronic trauma can be caused by open margin, calculus, cement that may stay there after your cementation, and when you didn't clean cement properly, this cement may cause recession. And another thing, actually, it may be caused by function, by occlusion. This is what you have to really understand. The functional problems may cause recessions. An example, this case, you can see recessions, and these recessions, by the way, they were compensated by composite materials, because you can see on the central incisor that there is composite in the area of recession. It's not like you have composite and then there is a recession, like if you will take a look on the premolar here, for example. That's composite here, and you have recession. So it happened later on. But in this case here, you have the recession. It's not visible on your screen. Okay. Anyways, on the central incisor, it's not. It's covered with composite. So what can be the reason of that? Okay, so that's the question. What can be the reason of that? And I would like to share with you something really interesting, important, and the things that not many people check doing dental treatments, restorative treatments, and so on and so on. We are speaking about the inclination of the palatal surface of front teeth, incisors and canines, that these teeth are responsible for dynamic occlusion, for protrusive and laterotrusive movements. And there is, according to the Rudolf Slavicek and Sadao Sato study, there is a correlation between this angle of the palatal fossa, palatal surface, and the condylar inclination angle, okay? So there is a correlation between that. So this is what you can see here on this slide. SCI, the sagittal condylar inclination, okay? And the palatal surface of frontal teeth of the central incisor has not to be steeper than 10 degrees to the SCI. In our case, but actually what is also important, but not greater than 55 degrees, okay? So 55 is actually limit. Let me go back to this one, okay? So we are still speaking about this case. And what we can see here, we can see recessions on central incisors, on canines, premolars. Now let's focus on the central incisors. We can, let me just do the speed test. Speed test. We're live. We're live. We continue. Let me just check again. Okay, so basically we came back from the internet disconnection. Can you hear me? Comments your pluses. I would like to see if you still can hear us and see us, and I will repeat what I actually was speaking about. Do we have internet? Yeah, we have. Yeah, it's like we live. I can see myself with our phone. Yeah, so we have response from our audience. They can see me, they can hear me. Sorry guys for this internet problems. I don't know what happens. So actually what I was speaking about the correlation between the angle of the condylar inclination angle and with the palatal inclination of the central incisor and the canine. And we were speaking that the maximum steepness has to be 55 degrees, but in our case that I'm sharing with you, we have 64 and 57. That means that these central incisors every day act as interference. So actually masticatory system, the poor mandible with a restricted envelope of function gets this interference, and we have every day we have pushing, kicking, punching, everything what you can imagine to these frontal teeth, and then you can get recessions. You can get tooth wear, which is actually very visible on his lower teeth. By the way, look at his lower teeth, and also we have the tooth wear of upper teeth from the palatal surface. Maybe you can see it from this perspective, and that's one of the reasons of the recession. So basically, you can do your preparations very well. You can do your cementation very well. Your veneers or crowns can be integrated into the biologic environment. Best fit, perfect transition, no cement, everything is super polished, but you may still have recession later on, not because of your retraction, not because of your rubidium isolation, but because of the steep angle of the palatal surface of the front teeth that may act as interference. So basically we have to check these parameters in these kind of cases, especially when you do full mouth rehabilitation, especially when you do veneer case, especially when you would like to make teeth longer aesthetic-wise. So this is what you have to check, my friends, because that's super important. And here what you can see, we can see here after, this is full mouth rehabilitation case, and that's the part of the wax up, prior final restorations, and we changed the palatal angulation by doing preparation and by doing this 360 veneers, if you want to call it, or crowns or semi-crowns. And we have now 55 degrees, so we can actually say that these restorations will guide the mandible. So we will have guidance, we will have movements, slight movements, so we will not have interference. So that's the result straight after cementation, and here we have before and after in that kind of big reconstructive cases where a lot of things have to be calculated. So that's the big topic about recessions, retractions, and also inclination of the palatal angle of our teeth. Okay, if you are interested in that, my friends, I would like to make some kind of advertisement. If you don't mind, I would like to introduce you or to invite you to attend our functional course that will be in March, and we will do it also in a regular basis here in our webpage, which is belograd.com. You can find functional diagnostics and treatment planning course where you will be able to see everything live. You will be able to see step-by-step diagnostic procedures, and we are speaking how we measure all these angles and how we measure everything related to the functional things that we have to take into consideration in big cases. Okay? Good. So do you have clinical comparison of the Modu and Zebris from Amann-Girbach system? Basically, I don't have any personal clinical comparison. I use Modu. I have the clinical comparison between Modu and KODC, which is from Gamma, like a conventional, let's say, condylograph from Vienna School of Interdisciplinary Dentistry. So I have both. I have KODC and I have Modu. But I don't have Zebris. I didn't test Zebris, to be honest. But I heard that Zebris is pretty good system. But again, I cannot be objective giving you any pros and cons about Zebris. I can speak about Modu if you want, but and I like the device, but Zebris is, I don't know actually, to be honest. I heard it's good. Can you give some tips how to handle scans of full arch preps? Okay. Full arch preparations. Let me see that. You know what I would like to say, my friends? We have now 37 people live watching our stream, and we have only 16 likes of this live broadcast. My friends, it's so easy just to put like. Please do that, because the algorithm of the YouTube will push this live broadcast for our dental community, and much more people can see this live or in a record. So please don't be lazy. If you like what we are sharing with you and actually our efforts, please put like and actually follow us, and if you can, it will be also very great if you can share this stream with your friends, so they can join and start asking questions during this live broadcast session. Okay? Good. So tips and tricks how to handle scans for full arch preps. Actually, not very long time ago, I posted a post on the Instagram. I will show you a slide now. And there was a post about a so-called intermediate scan. So intermediate prep. So basically what we have to do, we have to give our dental technician possibility to correlate the full arch prep scan with initial scan in digital articulator. Okay? For that we use so-called intermediate scan. This is what I would like to show you. So for example, here we have our initial scan. Okay? So that's the situation before. By the way, the case that I shown you just recently with these composite restorations. So that's the case. Okay, so here we have upper and lower jaw, but in the therapeutic position. Okay, so that's the therapeutic position. It can be CR, it can be video opening, or whatever. Let's say this is our optimal therapeutic position in which we are going to do our final definitive restorations. So now imagine you will have all teeth prepped. So the question is how your dental technician will be able to correlate the prepped teeth with this initial situation in optimal position. So basically we determine the bite, let's say, because some people they misinterpret or they misunderstand what is the bite record, bite registration, and so on. This is bite registration. It's already done during the process of functional diagnostics. We have it in the articulator. In this position our wax-up will be made. In this position our final restorations will be made. Okay, so now we need to bring full prep scan into this position. So what we do for that? We do intermediate preps and intermediate scan. What is intermediate prep? Intermediate prep means you have some teeth non-prepped. Like here we didn't prep last molars, and look, the last molar is the same initial and on our intermediate prep. So we can correlate this molar between these molars together, easy, because they are the same. Okay, and then we have some front teeth non-prepped. In this case, lateral incisor, for example, or canine or central, doesn't matter. So they are not prepped. So they are the same on the initial, and they are the same on my intermediate. Okay, so they can be correlated like that. The same things with the lower jaw. So now we have, you can see here, the intermediate scan is placed in the optimal therapeutic position, and now we have our full arch preps. So what will your dental technician do? Now your dental technician will correlate full preps with intermediate scans by prepped teeth. Because on intermediate scan, your molars, prepped molars, are the same as on the full arch preps. So they can use these teeth to correlate between each other, and you have your full preps upper and lower jaw placed in a digital articulator in the optimal position, in the therapeutic position. Okay, so this is how it works. If you want to know more about that, for example, if you would like to read or you will forget something, I would suggest you to go to our webpage, which is belograd.com, and here is the case and articles. The case and articles. Okay, so you press here, case and articles, and you will be able to see the text of the article about how to transfer the bite once all teeth are prepped. So you can see scans, the explanations also, and everything. Okay, so let's go next. So what we have here, we have now, just let me just check what we have on the live broadcast first. Yeah, thanks for likes, by the way. We have now more likes, which is amazing. How can I see chat? Live chat is here. Yeah, so good. Thanks a lot. Don't forget, like is easy, and I'll be happy. Do you use desensitizers under veneers? If yes, what is the protocol? Personally, I do not use desensitizers, but I know some people, they use it. So basically, yeah, let's make all this long story short. Personally, I don't use the sensitizers under veneers. Let's go next. I just graduated from university. When is the best time to start going to courses, and how to select them? That's an interesting question, by the way. I'm the one who is interested for you to go to the courses, because I'm providing courses. But what I can suggest you, our YouTube channel. You are here. This is our YouTube channel. You have playlists. When you go to the playlists, let me just give you a very short introduction. So when you go to the playlists, look, we have here dental tips, amazing series about tips and tricks in dentistry. We have webinars free of charge. We have dental talks, interviews with amazing people like trendsetters in dentistry. Okay, we have one dental minute series. We have dental case reviews, like a small webinar series about the clay case presentation. So we have a lot of information free of charge on our YouTube channel. So if you are just freshly graduated, I think that our platform will be one of the best to start getting into the modern trends of dentistry and so on and so on. So I would like to advise you to go to our YouTube, and then probably you will be able to choose the topic that you are more interested in. I mean, if you would like to deepen up your knowledge in some of the topic, then you can go to the course. So you will feel it yourself. But I personally, I started to attend courses very early. And I regret that I didn't start to attend courses earlier than I could. That's the thing, because course, if we speak about the hands-on course, for example, or even theoretical course, especially for the fresh graduated people or young dentists, this is one of the best and easiest way to collect information in a specific topic you are interested in, because you go and somebody already prepared everything. You can do a lot of things yourself, like a self-education, books, articles, YouTube, webinars, and so on, but it takes time. But if you go to one place to the specific topic, you get the full package of the information, motivation, structure, and everything, and then you will be updated. So you decide when it's better for you to start doing courses. So first, this is what you can go for the YouTube, and then let's go to the courses. Okay, so next question, actually it's not a question, but it's very warm words. I and my friends love you and your work. You are the best. Thanks, my friends. It's really, really great to receive nice feedbacks. Actually, it's motivating. We are all humans, and we like to be admired, let's say. Yeah, anyways, thanks a lot. We really appreciate it. Okay, next question. How do you check the occlusion before direct restoration, or do you? If you do, how? Okay, so when you do direct restoration, it's a very simple thing. You just take your articulating paper and you just check the ICP, intercuspidation, and then you can actually take a picture of that, or you can even point it with some water-resistant marker. So when you will layer your composite, you will not overlap it. For example, then you will have no problems with adjustment of the occlusal surface. That's one of the tricks that you can try in your practice. Okay, is overlap veneer prep still an option? That's a good question, because you know, the incisal overlap or wrap around preparation considered to be nowadays an old fashion. If we speak just about veneers without any kind of occlusal issues, occlusion problems, we can do so-called butt joint. That's easier. Easy to prep, easy to manufacture, easy to produce, very strong. Yeah, so actually insertion path, conservative preparation. So there are so many benefits to do butt joint. This is what we do for our veneer cases. So we don't do any more incisal wrap around, because recently in the past, incisal wrap around was an option because it gave some extra mechanical retention. Okay, so nowadays it is proven that we don't need to do any mechanical retention. We do bonding, and your veneer will be bonded perfectly, and you will be not able to remove it. Okay, so we are about to bond our restorations. But if we take a look at this case, it's a very compromised case, to be honest. I was forced to do veneers for the one famous plastic surgeon. But anyways, there is a background in this case, but let's focus on our topic. So we have recessions on canines and we have recessions on premolars. Look at them. And by the way, we have also ask questions about how we make our margins for veneer preps or crown preps if we have some recessions. Okay, so this is actually the demonstration where I will ask the question about incisal overlap, veneer preps, and also recessions. So here we have recessions, and if you were attentive, we were speaking about the steep position or steep angle of palatal surface of central incisors and canines, and here we have the same thing. Okay, but for canine the angle is more shallow comparing to incisors, so the maximum that we can have is 50 degrees. In here, we have 58 and 52. So canines, in that particular case that I'm sharing with you, act as interference. That's why this guy has recessions. So what we have to do? orthodontic treatment, best way. We procline, we have much more freedom for mandible to move and so on. Complete refusal of the orthodontic treatment, and then according to our plan, we decided, okay, we can do veneers, but we need to change palatal inclination there. S1 and S2 points. Okay, S1 when there is intercuspidation, S2 when you slide. So in this case I did overlap. I did veneer with incisal overlap, and by this preparation, maybe on this slide you can see the palatal margin of veneer in the canine. And by the way, you can see also cervical preparation there. I included the apical portion of recession as the reference for my preparations, but we will speak about this later on more in details. I mean about the preparations for veneers or crowns and when you have recessions and so on. We will speak about this a little bit later in details, but just here you can see how I did it. Okay, so we made this incisal overlap, not because we want to have stability, not because it is stronger. It is not stronger, by the way, but because we changed the palatal inclination. And here we can see that it is 49 and 50 degrees. So now we have much more freedom for mandible to move, and I'm pretty confident that there will be no recession because there is no interference. So that's why we did this overlap. So sometimes our preparations are driven functionally. So that's the answer. So that's the final result. Okay, and next question. How do you find same-day milled Emacs? Pros and cons, please. You mean chair side Emacs if you do it yourself, for example, same day. You prep today, you scan today, you mill today. So it's fine. When you do your restorative workflows, like a single units or some quadrants, for example, overlays or whatever, why not? If you have a small lab in your practice, or maybe you do it yourself, so why not? I cannot give you any pros and cons because I don't do that. I still work in a conventional way with a dental lab, but I'm not against this approach. Why not? It's pretty convenient and fast. How you use Modu? Do you do KODCs? Yeah, actually, I already answered that question. Yes, I use Modu. I also have KODCs. Just a few things difference. The Modu is a very easy and user-friendly device. The recording will take you like 15 minutes, maybe at the whole process. I mean, from installation to the final 15 minutes. So it's easy. It's very visually controlled. It's an amazing tool because it gives you possibility to control so many things about function, dynamic, static, interferences, measurements, everything. Okay, so we use it for all our cases. Veneers, full mouth rehabilitation, big cases, we always use this kind of stuff. KODCs actually is from Gamma. It is more complicated. It's much more difficult to work with, but it's not much, but it's, let's say, it is, how do you call it? It's more expert oriented, I would like to say, because Modu can be used for wide public, let's say, but KODCs is more expert oriented because, for example, what we cannot do in Modu, we cannot make destruction of the condyle. We can do it in KODCs. What we can do in KODCs also, we can program each condyle separately. So we can move left condyle and right condyle separately. You know, one forward, 2 millimeters, one just 1 millimeter, one destruction, 0.5 millimeter, another one no destruction, and lateral shift, for example, 0.5 millimeter to the right. So this is what we can do in KODC. So basically it's more for advanced TMD cases, let's say, but you have to have a very good background knowledge to use it. Modu is more user-friendly, more wider, but still to be able to use these kind of devices to make a proper interpretation, you need to have a basic knowledge about function, occlusion, and data interpretation. This is what is necessary to know. And again, I would like really to invite you to this course because this is, I think, one of the most practical 2 days course when you will be able to see analog way, how we can do it in a conventional way, Facebook, CR registration, muscle palpation, occlusogram, articulator, which is also device that has to be used by dentists, not only by dental technicians. So there are so many things and intakes that you can get from the articulator. And during this course, you do the full protocol of the Modu on the live patient with the old interpretation. We make a comparison between analog and the digital, and there are so many intakes, pros and cons, and tips and tricks during this course. So if you're interested in this topic to deepen up your knowledge, please more welcome to our academy. You can find this course on our webpage, belograd.com, hands-on courses, functional diagnostics and treatment planning. Okay, good. Let's move on. What is your protocol for fiber post cementation? That's the question. Fiber post cementation. Basically, you need to read instruction because there are different types of fiber posts. Honestly speaking, there are fiberglass posts. There are some posts that are already impregnated with a resin by manufacturer. There are some fiber posts already silanated by the manufacturer. So you need really to understand what type of fiber post you are using. Let me show you a slide. That's like a conventional protocol if it's not silanated, but it is fiberglass post. So you have some glass particles. You can disinfect it with ethanol, and then you can use silane, and then you can use your bond. You can skip silane also when you can use this kind of multi-modes adhesive systems like a Scotch Bond Universal, for example, which has some light silane inside. So you can just disinfect the fiber post, then you can apply this MDP and silane contained adhesive, dry it, cure it, and you have everything. This is how it can be used. It's easy. Okay, patient's head position during the crown preparation through the microscope. It's a big topic. It's so difficult to really explain you by hands. But if you want to see some episodes of the workflow with the microscope and patient's head position during direct view, when you do preps and direct vision, or when you do your mirror, I would really suggest you to go to our YouTube channel, which is here, okay? Then you go to playlists, then you go dental tips, and here dental tips, okay? And here we have the benefit of using microscope. The benefit of using microscope, the benefits of using microscope for canine crown preparation. So that's the live action from the course when I was helping participants to master their preparations with microscopes using mirror and direct vision. So I was guiding and speaking and showing you the head position of the patient. So you can really check this video, which is 10 minutes only on our YouTube channel, and you will get pros and cons about these kind of situations. But if you would like to go more into this field, molars, molars, you know where to go. You go to BJ Academy Prague, big prep course, and you will be like a Shaolin in preparations with a black belt. Okay, how do you prevent handpiece water spray from reaching the mirror during indirect view? That's also a practical question. Let me show you. So that's the upper last molar. Actually, that's the upper second molar. Okay, so you can see first the mirror is placed relatively far away. So actually it has to be placed as far as you can. Okay, that's the rule number one. You place your mirror as far as you can. Then, yeah, so then we have a suction from the assistant side, the high volume suction, that is also placed pretty close to the mirror. Sorry, not to the mirror. It is placed very close to the tooth that you are prepping. That's important. So the suction, the high volume suction placed to the tooth that you prep. So basically the water spray from the handpiece will be efficiently evacuated by the high volume suction. That's the rule number one. Okay? The rule number 2 actually. The rule number 1, you place your mirror as far as you can. Then you have high volume suction to the tooth area. And then your assistant will take the water syringe. Actually, we need air syringe. And the assistant will blow air to your mirror to get out of the water that it will still appear on the mirror during preparation. So this is what you have to do. Assistant has to be efficient in that. So high volume suction, then the air water syringe. You still have water, you see, but you can still things, so you can continue. In this case, I also show you the small mirror. That's actually the advice to have the small mirror, very small, like a number 0 or 1. Sometimes you have not enough space to access the this is distal, a buccal distal transition of the second upper molar. It's difficult. But with a small mirror, we were able to access this zone, and your assistant was efficient using the high volume suction and the air spray. Okay, I want to learn veneers. Where do I start? Digital smile design, prep, bonding. I love these questions because what we have, my friends, big veneer course. 3 days from start to finish, from treatment planning, patient communication, lab communication, smile design, mock-ups, preps, try-in, bonding, rubber dam, everything, completely hands-on. Here you can see dates to 2025 on our webpage. We will be more than happy to see you and to teach you how to do veneers from 0 position. Okay, let's go next. You have done bonding protocol right, but patient cold and 2 veneers have fallen. Oh, that's pain, my friends. If it happens, it is pain. So what I can say, if you done the bonding protocol right, but 2 veneers have fallen, it means probably you didn't make bonding protocol right. Obvious, right? But anyways, sometimes it may happen that you will really follow bonding protocol completely, strictly, everything was perfect, but you still may get some debonding, and there are many reasons of that. I think that we will record a special video series about proper bonding for veneers, because it's not just a protocol like a hydrofluoric acid, silent bond, and so on. It's not just about that, but there are a lot of small things that you will have to take into consideration. There will be a few videos, and I think after that you will have no problems with debonding. So let me show you one thing. Okay, so here we have a process of bonding to veneer. Let me just skip this process: the etching, rinsing, then bonding. Okay, so we place a resin cement to veneer, then to the tooth, and then I clean the excess of cement with a brush. And then let me just tell you one thing, okay? I know that many people, when they do veneer cementation, they do so-called tack cure process. Tack cure is when you cure your veneer or crown or whatever just few seconds, like 2 seconds. So this cement excess that is outside becomes very soft and easy to be removed. Okay, and then you continue. So this tack cure, which is very common type, or let's say part of protocol of cementation, is not good for veneers. I would not suggest you to do tack cure at the beginning, okay? So it's actually forbidden because of many reasons. The one of the reason is that, I will show you actually, it's better to see. Just let's have the full screen here. Look what I do. I press on the veneer, then I don't press, then I press again, I don't press, and then I press again. So what happens? It happens that there is spacer actually. Dental technician uses spacer to create this space for cement. And if spacer is big, for example, or even if it's not big, if it's normal, like a less than 100 microns, there is still space. So when you press a bit, veneer sits on the tooth surface, but when you don't do any pressure, it goes back. So resin cement is still underneath. It's like breathing. So when you do tack cure, your veneer may be placed not to the surface of the tooth completely as it should be, but it may stay on the very thick layer of cement, and this layer of cement shrinks. Okay, when it shrinks, it may cause debonding. It may cause postoperative sensitivity, by the way. So what you have to do is not to use tack cure. You have to cure it in a different way, okay? In a different way. You press, you hold, you cure from the lingual side, then partially from the buccal side to stabilize it. Or you can use so-called spot cure. When you're doing a center thin electrode, you spot cure 20, 30 seconds, so veneer is completely stable, and then you can do whatever you want. So try to avoid these tack cures at the beginning of your veneer cementation, and you get less and less problems with debonding. Okay, next question. Dry prep isn't harmful for pulpa. I don't know really how many times we were speaking about this question, how many videos were presented, how many stories were presented, but still people are confused about dry prep approach. So first of all, look, this is our protocol of preparation. So we have step 1, step 2, step 3, and step 4. Okay? So step 1 and step 2 are main steps of preparation when everything has to be done. Space for the restoration, aesthetic transitions, and insertion pass. So basically all preps are finished. We do it with water, we do it with a relatively high speed. We use different types of the bores and different, let's say, aims at stage 1 and stage 2, but anyways, it's done. And then when you go to the step 4, when everything is done, you go with your red or yellow diamond bore, just 10,000 RPM, air spray, and you don't prep. You refine your margin. You make a massage of your margin, okay? The margin becomes smooth, but margin is already done. Margin was already prepped before, so we don't do margin. We just smooth it with a bore. With this speed, everything becomes super smooth, super precise, and super smooth, and there is no risk to have pulp barbecue, my friends. So it's not harm for the pulp, it's safe, it's easy, predictable, and precise. Okay? Good. Let's move on. So we have here how to prevent post-onlay cementation sensitivity. Okay, so we have 55 people watching us live, and we still have only 41 likes, my friends. There is no equivalent, number of people watching our live stream and likes. Please don't forget to give us likes. At least it's so easy for you. I'm giving you so many information that is not free of charge during courses or during conferences or during the symposiums or whatever, but on our YouTube channel we are really happy to share this information. So I think it has to be like a light win-win, okay? So please don't forget to put like, don't forget to follow us. We are now 100,000. We have 100,000 followers. Thanks, by the way, for following us. And we will do more and more educational videos that are useful for our colleagues, for young people, for young generation of dentists, and also for other dentists as well. So I think that will be more and more. Okay, let's move on. How to prevent post-onlay sensitivity? That's the question. So basically, no spot, no tack cure, as I told you. The preparation surface has to be smooth. So that means how do you say, I just forgot the word. Spacer. Yeah, the spacer will be also very light. So that means the cement layer will be thin. There will be not many composite resin, not many shrinkage, so it will be fine. And also you have to follow the bonding protocol very strictly, so then you will get less postoperative sensitivity. Also, you have to check occlusion. What we don't have to have premature contacts on the teeth and also interferences. which may cause postoperative sensitivity, by the way. Good, perfecto. Let's go next. When injection molding, that's the question. When injection molded. For me, honestly speaking, injection molded is more like a temporary solution, or semi-temporary or long-term temporary restorations. Some people use it like a final restorations for low-cost patients. Let's say, why not? Why not? But I'm more into like ceramic restorations, full mouth rehabilitation. So I use sometimes injection molded in my practice, but more like a temporary solution. Like in this case, we created 2 temporary crowns on central incisors. We made them a bit slimmer, the teeth, centrals, okay? And we get some gaps between centrals and laterals, and we filled up these gaps by using injection molded technique on lateral incisor, like you can see here. We did line etching, line bonding, and we did the injection molded for a few months, just to check how this black interdental triangle between these two centrals will behave. So we created these two central incisors. These are PMMA crowns, milled PMMA crowns, and we wanted to test drive the profile of the teeth to see the soft tissues response. So we used also the injection molded here as the temporary solution, and then later on we changed these restorations to ceramic. So lateral incisors were prepped for veneers, and centrals were transferred into ceramic crowns. So that's one of the ways I do my injection molded. Okay, how do you establish veneer limit on teeth with non-carious lesions like abfraction, for example? Okay, so we can actually add here the similar question about recessions. So you remember we were speaking about this. So when you have recession, or you have a recession and abfraction, let's say, so first of all, what you have to think about? You have to think about the reason of that, why recession happens, why abfraction happens, and you have to decline the reason of that. That way you will have the stable result of your restorative treatment. Okay, so that's the thing. Now let's say we have everything done from the functional perspective. Now we are going into our final run. We are going to do our final restoration. So now we have the recession or abfraction and so on. So there are many actually steps, or many options. There is not only one way. You have to prep that much, or you have to keep your prep on the coronal area. So first thing, you may think if you can do connective tissue grafting. So you do surgery, you wait, healing, and then you do your veneers or crowns. So that's the best. If you cannot do surgery because, for example, there is a vertical and horizontal bone loss, and you have abfraction, and you have this also root exposed, and so on. So basically now we are speaking about very compromised case. Very compromised. Functional compromise, aesthetic compromise, biological compromise, and so on. And in this case we have few options. The option number one, you will prep that much till the apical level of your recession of abfraction, so that will be your finish line. But you have to be ready, the teeth may be very long afterwards. Okay, then what you can do your preparation in the coronal part, so there will be the conservative preparation, and then you can add some composite material in this exposed root area, which is called sandwich technique, or bilaminar technique, or hybrid restoration if you want, ceramic and then composite. It is conservative, but in the long run you may see the difference between ceramic and composite surface, so you have to be ready for that. Okay, then what you can do your just preparation in the coronal part, and then you put filling in the abfraction area. It may work in low lip line patients, well educated, intelligent patients. Then what you can do, you can make extractions and all on 4 or all on 6, or you can just refuse for the treatment. You just show to your patient where is exit from your clinic, and then that's it. So these are options, and you will choose which one is better in your case. So here we have the question about type of bonding. What do you prefer for direct restoration? I use this. I use this one since 2000, I don't remember, 2007 I think, for everything, direct, indirect. So I think this is one of the best adhesive systems still on the market. Fourth generation, conventional classics, golden classics. The only thing that you have to be worried is when you use dual cure cement or let's say core composite, not all of them are compatible with Optibond FL. So in this case, I would suggest you to use original adhesive to dual cure cement rather than Optibond FL. I still have a lot of questions to answer, to be honest, but we are almost 1.5 hours online. I think that it's better for me now to answer some of questions that we have in this chat. First of all, let me check if you place likes. Yeah, we have now likes. Okay, thanks a lot. So now we have 51 likes. You see, when I ask people put likes, why don't you put likes without asking? Don't forget to put likes, by the way, when you will watch our dental tips series. There will be new episodes of that. Very interesting project. So yeah, let me answer questions here. We have dental office question. Do you plan to switch your Prime Scan to Prime Scan 2? Actually, I would like to try Prime Scan 2 first to see how it works, to make some test drives, and then I will decide, because I'm really happy with my Prime Scan 1, to be honest. But I will see. Okay, so we have the question from YC. Is there another method of correcting the blue or gray color that can show on the cervical margin when crowns are prepped under the gingival line, impinging on the gingiva and violating the biologic width? So first of all, you need to prep without violating biologic width. So that's the way. Okay, but if you have the case when patient comes already with an old crown and you have this violated biologic width and this kind of specific view over soft tissues like a blue, red, as you said, so you have few options in such a case. The first option, maybe the problem is caused by the biologic width violating during preparation, but also because of the bad fit of the previous restoration. So what you can do, just a simple thing, you may just get the new well-fitted temporary restoration. It has to be superiorly fitted, okay? And maybe it will be okay. Later on in a 2-3 weeks, you will see the result. If it's not, then you have two options. The option number one, you can do BOPT, okay? This kind of knife edge BOPT preparation, or you have to do crown lengthening. Dana, when you restore the anteriors with veneers after increasing the VDO, won't the ceramic chip if it was more than 2 millimeters, especially if the patient has abraded and short teeth and we want to lengthen them? That's a good question, Dana, but actually when you do full mouth rehabilitation and increasing VDO, you redesign the occlusion. So everything has to work then properly. You have to have good and stable static occlusion and dynamic occlusion without premature contacts and interferences, and you have to have enough envelope of function without limitations. So no steep positions, no closed arches, and so on and so on. So in this case, everything has to work perfectly. That's why we actually do full mouth rehabilitation, because we want to rehabilitate the whole system. So veneer may not break. I cannot say it will not break, because everything may happen, but if everything done correctly, treatment planning was correctly. Treatment planning is a pain. I would like to show you something, because we had some question here like full mouth restoration tips. Please, can we have slide? Yeah, full mouth rehabilitation tips, but this is actually the question that is connected to your situation. So look, this is for easy cases. 13 different steps to perform, to check every time we do treatment planning, then we test by, then we check, then we do provisionals, then we check, we do functional diagnostics again, then we do final restorations on lower, then we check, and so on. So multiple control over the process. You can take a screenshot to have it like a cheat note or cheat sheet for your daily practice. Okay, but it's a big work. In full mouth rehabilitation, it's a very, very, very big piece of work. So everything has to work perfectly afterwards. Let me continue with my friends. Let me continue with your questions. So let me go to another one. I would like to answer your questions, because I still have a lot in my presentation. I think we will have to do part 3 or even part 3, part 4, and so on. So many. Okay, good. Where is GC Equia Forte HT for load bearing areas for clinicals from third world countries? I don't know. I didn't get it. Second question is use of indirect composite overlays in biomimetic approach for patients who cannot afford IMAX. It's just a statement or it's a question? If it's statement, you can, why not? Now, what kind of rubber dam clamps? Days Krasko. What kind of rubber dam clamps band do you use for veneer cementation? Thank you so much for your time to do the Q&A. Thank you for participating. Thank you for your question and for your time as well. I use Brinker clamps from Hygienic. You know the company Hygienic. They have Brinker clamps. So I use Brinker 4 and Brinker 5. These are my 2 favorite clamps for veneer cementations. Apris Dennis, Master, thank you for mentorship. Special greetings from Ghana, my friend. Thanks for being with us and for following us. I do my best. Svetoslav Parashuk, could you please tell me what do you usually use for dentin, dehybridization, and veneer cementation? If you ask about immediate dentin sealing, I use Optimon FL. So I use also Optimon FL for veneer cementation, and I use actually, me personally, I use highly filled flow composite for that. I use General Universal Flow Injectable to cement my my veneers. This is what I use. Okay, Mexico, how do you adjust the margins? Radoich, Dr. Radoich, how do you adjust the margins and occlusion of partial coverage restorations? It's a pain. By the way, let me show you something, because there was also a question about non-prep veneers. Okay, let me just check it. Wait a second. Yeah, so here we have what is your intake on non-prep veneers and actually partial restoration. So what I would like to suggest you, I would like to share with you one article. You can go to our webpage, belograd.com. Okay. Then you go to cases and articles. So we have folder cases and articles, and you may find these partial veneers from Facebook. It's a big article. Read it, and then we will speak. Read it, by the way. That's actually, that will be our deal, okay? You read the article, and then we will save this live broadcast, so it will stay in our YouTube channel, but then please come back and in comment, write down what you think about this article, okay? I really want to know your feedbacks, because I put a lot of efforts and emotions to read this article, and I would really like to know your feedbacks, guys. So if you can, please read it, and then in this live stream later on, just tell me your feedback, or more, maybe you may share some of your experience in such a cases like a non-prep veneers or partial veneers. Okay, good. Can we place the incisal butt joint of the veneer on composite? Theoretically, we can. And actually, practically, we can. We have so-called hybrid restorations, bilaminar technique, and so on. So basically, you can. YC, thank you for answering my questions. My pleasure. Okay, so Iana, let me check, or Lana, Iana, maybe. If you have class 4 defect, you open contact proximally during preparation teeth for veneers. Yes, we do. We have class 3, class 4. We do our type 3 veneer preparation with interproximal surface complete opening, or just for class 1. And for class 4 defect, what kind of preparation do you do? I don't do overlapping. I just do my type 3 preparation. So we basically will have a veneer on the buccal surface, and we have veneer on the proximal surface, but palatal surface or lingual surface will stay like it is. It will stay with composite. So we can make combination. Dental office. What gives us muscle palpation during diagnostics? First of all, you need to understand what kind of muscles we palpate on and what are the functions of these muscles. So when you see some muscles are in pain and you know the vector of these muscles, you may understand what happens in the patient's mouth. Mandible shift, the lower facial height diminished, or let's say the decreased vertical dimension or something else. So it gives you a lot of information about the system, how the mandible stands, which muscles act as norm, which muscles act as in norm. For example, when you have interferences in the back areas, it may happen. So basically, a lot of stuff. You can read about that, but by the way. Okay, so we have Virai. Best way to clean excess after online cementation. I do with a brush, with a floss before curing, and then everything is clean already. Then I do curing. I do, let's say, spot curing, and then I can do tack curing, and then I can clean. Dana, so for clarification on the previous question, veneers can be longer than 2 millimeters. Yes, they can be longer than 2 millimeters. They can be even 5 millimeters. Veiko Radojic, how do you pre-treat dentin when doing IDS? So basically IDS, immediate dentin sealing, it is a simple process. It is simple. It's like, for example, forget about IDS. Forget about all these fancy terms. Think about how do you do your composite restorations. You have class 1 caries defect. Okay, you prep it out. So now what you are going to do with your dentin? Etch, rinse, bond, right? Or self-etch and bond. So the same way. If you want to know more about this IDS, you know what you can do? We can actually, can we have on my screen? So again, you go to the YouTube channel. You know, you are here already. So you go to playlists. And look here, webinars. Okay, so we have webinars. We have immediate dentin sealing, free webinar. Please, where is it? Yeah, here, free webinar, 30 minutes of information. Please read it, watch it, and then no questions afterwards. Okay, let's go next. The path of insertion in type 3 is buccal. If yes, the proximal preps should be parallel and not wrap around the palatal. Yes, my friends, if we speak about veneers, there is no wrap around, no palatal, chamfer, bevel, nothing. The insertion path in type 3, it's ideally buccal, but it's not buccal always. It can be 45 degrees from incisal edge. It can be from incisal then buccal, from buccal to incisal. So it actually depends on the type of the tooth. But it's not like a crown, it's not vertical. So that's the thing. YC, what kind of X-ray sensor do you work with or recommend? Actually, I have a very old sensor from Kodak, Kodak RVG 6100. I think it's not in production anymore, or maybe it's still on track, but one of the best sensor in quality of imaging, one of the best. Do you sandblast the dentin prior to etching? Me personally, I do. I do sandblasting before etching. This is what I do in my typical cases. So I use sandblaster in my practice. Okay, my friends, I think that's enough for today. We will do another live Q&A, but next year. This is the final one. I would like to thank everybody for your participation, for your likes. Now we have, by the way, more likes than people watching us. So basically, we will keep on track. We will save this live stream. Please share this live stream with your colleagues. Let them see this, because I think that we were speaking about important things openly, freely, with deep explanations. So I think that a lot of colleagues will find this very useful, and we will contribute in our dental education globally, worldwide. Then what I would like to say, I would like to wish you all the best in the new year. I would like to wish you Merry Christmas, that actually already done, but I would like to wish you Happy New Year, to be strong, to have to enjoy your profession, to enjoy your life, to enjoy your cases, to have more and more pleasure on the work, to be well paid, to be able to afford what you want, to be able to afford any equipment you want, to be able to afford any material you want, to have good patients, very humble, very cooperative patients that you really enjoy to work with, and be happy in your personal life as well, because dentistry is not only our life. We still have to think about our personal life, and I would like to wish you to be happy in your personal life as well. Thanks for watching, and as usual, may the dental force be with you, my friends. Goodbye.